Hi, my name is Randy Hecht, and I'm excited today to talk to you about colorectal cancer for research to practice. I'm a professor of clinical medicine and also director of the UCLA GI Oncology program. My charge today is really to talk about targetable alterations in colon cancer, and also since it's really hard to get away from how we test for this. So let's go through some of the targetable molecular alterations that we will see in colon cancer. Some of them are FDA approved. That includes MSI, which unfortunately, because those patients do so well, and that's not really part of the purview of this talk, that's only about 3% of people with metastatic disease. We'll talk about BRAF, particularly V600E mutations, which is more common in about 5 to 10% of patients. HER2 amplification and overexpression is found in about 5% of colorectal cancers, not just for breast cancer or gastric cancer. And then there's some rare ones that we keep looking for, like NTRK or RET fusions. And I have to be honest, I haven't seen one of these yet. These are really vanishingly rare, though we do have drugs for those. Likely soon, we'll actually have approvals for KRAS G12C, but while more common in lung cancer, is only found in about 3% of colorectal cancers. And finally, I'll also talk about what I call aspirational targets. We're really hoping that we're going to be able to hit the 50% of colorectal cancers that have RAS mutations. Right now, it's only useful for telling you what not to do, and what you shouldn't do is use anti-EGFR antibodies in patients who have RAS mutations in their tumors. So, next question is, well, how should one test? Initially, when I first started working with panitumumab, we were doing really just exon 2, looking at codons 12 and 13. Then we've moved to larger panels that are still fairly small, looking particularly at RAS, BRAF, perhaps HER2, occasionally some other things. But we're really moving to NGS, which gives you 500 to 600 different genes that are often mutated in cancers or altered. This gives you that potential to find those rare targets that we're looking at. NGS is also more tissue conserving, because rather than looking at each target individually, they're multiplexed. So many of our patients, if they did not have surgery, only have a biopsy, perhaps even a fine needle, not a fine needle, but a core biopsy that has a relatively small amount of tissue. Also, even if something is not FDA approved, that an alteration may make the patient eligible for trials, and we should always be looking to do things better. Now, over the last several years, the idea of liquid NGS or liquid biopsy has really come to the fore. And as I work with my colleagues in the community, I see more and more patients, rather than looking at the tissue, are getting liquid biopsies or NGS. Now, there are some advantages to that. One is that you don't have to track down the tissue. Also, particularly for RAS, you may get the results back faster, but there are some other questions with that. One is that tissue may have better detection, particularly of actionable mutations. I'll talk about this on the next slide. Though liquid does have some potential advantages over tissue. Once again, if there's very little tissue, or perhaps it's already been exhausted with other tests, you can do this. The other thing is that often the tissue NGS is just done at the time of initial diagnosis. It's harder to rebiopsy someone just to get another NGS, and things do change, particularly in patients who've been treated with anti-EGFR antibodies. And following a liquid biopsy or NGS may give you a more current idea of what the molecular state of the tumor is. So these are two trials that I were able to find. One is from Bale that was published in Annals of Oncology last year. This is from a large French NGS national trial called PRISM, and they looked at either liquid or tissue. This is not all colorectal cancer, but if you look at the Venn diagram, while the majority of patients, if you had an alteration, you could find it on both. And when you find these alterations, there are a number of different ways to grade them. This is called SCAT 1 or 2, which means they're probably actionable, as opposed to other ones which we find that may not have any drugs for them. And if you look at, while tissue is more sensitive, probably for things that we have drugs for, that also you find things in liquid biopsies, probably resulting from the molecular evolution of the tumor. And another way to look at this is John Strickler, who we'll talk about in the in just a few minutes about the Mountaineer trial, which was for HER2 positive cancer. They actually recently presented at ASCO data looking at blood versus tissue and blood NGS, and they also used IHC and FISH as another way of looking at it. And IHC FISH, which is historically how we've done HER2, actually had a pretty high correlation with tissue NGS, not so great necessarily with blood. And so I think I think the jury to a certain extent is still out, particularly for HER2. That's a great segue to talk about HER2 and colorectal cancer. HER2 amplification is found in up to 5% of colorectal cancers. One thing that's been shown in a number of different series is that patients who have HER2 amplification are significantly less likely to respond to anti-EGFR antibodies, and you would probably consider not using them. This has led to the term triple wild type, meaning RAS wild type, BRAF wild type, and HER2 wild type as the ones that are most likely to respond to anti-EGFR antibodies. Older agents really didn't show a lot of activity in colorectal cancer. We ride on the backs of our colleagues from breast cancer, who really developed HER2. Some of the earlier trials then looking at combinations included the Heracles trial with trastuzumab and lapatinib, an older tyrosine kinase inhibitor that I've run trials with, and showed a reasonable response rate of 28%, though the PFS, as often is the case with signal transduction inhibitors, was relatively short. A MyPathway cohort, this was with multiple different cancers, but in the colon cancer cohort, trastuzumab plus pertuzumab had a similar response rate, though a little bit shorter median PFS, though a few patients could have made a difference with there. So let's look at more modern agents. And the first one we'll talk about is tucatinib. That's a very selective small molecule tyrosine kinase inhibitor that has a lot of activity in breast cancer. And John Strickler, who I mentioned earlier, started the Mountaineer trial, which I have to give him credit, was an investigator-initiated trial. And then as it looked more interesting, was expanded to a global trial. And you sometimes need really global reach in order to do something that's only in 5%. Heracles took the entire country of Italy, for example. And so this study had two parts. On the first part, cohort A was just single arm tucatinib plus trastuzumab. And then the second portion was randomized between that combination versus tucatinib monotherapy. And the endpoints, this was a sort of a phase 2 trial. In particular, we're looking at response rate. And then for the second part, also looking at duration of response. So this is the waterfall plot from the combination. As you can see, the majority of patients had some sort of shrinkage of their tumor with the combination. So there's a 38% response rate. PFS was actually pretty healthy at 7 months. And considering this is a salvage group of patients, though maybe carefully selected, the overall survival at 24 months was actually pretty robust. Unfortunately, the monotherapy arm really had a very low response rate. Now, in that study design, patients who did not get a response, which was almost everyone, to monotherapy could cross over the combination. So you really can't look at PFS with that. But in that group of patients who crossed over, a reasonable percentage had responses as well. The main toxicity was diarrhea. Only about 4% of patients actually had grade 3 diarrhea, and this was approved earlier this year. This has led to a larger randomized trial. This is the Mountaineer 3 trial. This was in HER2 positive, which means 3 plus or 2 plus IS positive, in good performance status, randomized between the combination, this is upfront, of modified FOLFOX6 plus the doublet of tucatinib plus trastuzumab versus a control arm of modified FOLFOX6 plus Bev, and what I would not use an anti-EGFR. Primary endpoint, because the trial is a little on the small side, and this is a first-line trial where PFS has been used as an endpoint, is PFS with routine standard secondary endpoints. Let's talk about another drug that has activity in breast cancer. Once again, kind of trickles down from breast cancer. That looks exciting in metastatic colorectal cancer. That's trastuzumab deruxtecan, or TDXD. This is a sort of a newer generation antibody drug conjugates. Everyone here is familiar with antibody drug conjugates with an antibody, a linker, and then a payload or a warhead. And there's some differences with this from some earlier generations. One in particular is that the drug antibody ratio, or DAR, is higher than, for example, TDM1, an older version. And so that seven or eight molecules of the warhead are on TDXD. I think also really important is that it's a camptothecin, which we know has activity in colorectal cancer, while TDM1 is a tubulin inhibitor, which is pretty inactive in colorectal cancer. And that may explain why it's a better drug, much better drug in colorectal cancer. One problem with GI cancers, such as gastric or colorectal cancer, is that there's a lot more heterogeneity. So you may have HER2 positive cells right next to HER2 negative cells. And one of the ways that ADCs work is by a bystander effect. Some of the warhead may either leak out from a dying cell or fall off before. And this is, once again, looking at TDM1 versus TDXD. And what you can see is that there seems to be significantly the one on the right, which basically has no viable cells, even though it's a mixture of HER2 positive and HER2 negative, that TDXD was much more active in that heterogeneous tumor. So this led to the Destiny CRC01 trial. This was in patients with metastatic or unresectable colorectal cancer. They had to have some sort of HER2 expression, and I'll talk about that in just a second. Some patients who are HER2 positive actually have RAS mutations, so that is a subgroup of patients that probably don't respond as well. So these patients had to be wild type for that and BRAF V600E. They could have had prior HER2 therapy. So there are three cohorts. The first was either 3+ by immunohistochemistry or 2+ plus ISH, FISH or SISH. And those are the patients we would normally treat, for example, with trastuzumab with a patient. They were also looking at sort of interesting cohorts B, which were HER2 2+, but ISH negative. So presumably not amplified, but still had the target. And then I know in breast cancer, there's a lot of work in sort of HER2 low. And so this was a 1+ group in colorectal cancer. So primary endpoint was response rate with the usual secondary endpoints. And in cohort A, 3+ or 2+ ish positive, there's a very high response rate, with actually particularly high response rate in the ones that were 3+. Not surprising with an antibody drug conjugate, with, once again, a robust progression-free survival and good overall survival. There was 0% response rates in cohorts B, which was 2+ ish negative or 1+. However, the disease control rate was actually reasonable, though I'd probably relatively short-lived in that 2+. So I do think there's something there. Now, many in the audience are familiar with TDXD, particularly in breast cancer and other cancers. Main toxicities are really from the payload with cytopenias. It is real chemotherapy. And also something in particular, which is pneumonitis. Up to 10% of patients, almost 10% of patients had pneumonitis. This is actually from another patient, but you can see to the right, which resolved. And not only was there pneumonitis in this trial, but almost 4% had grade 5 pneumonitis, meaning death. So these patients have enough problems, something that was really concerning with that. So this led to the Destiny CRC02 trial, which Dr. Raghav presented at ASCO. And this was looking at different dosing. And we'll talk about that. The FDA, through Project Optimus, really wants us to get the correct dose. We've shown in drugs like irinotecan or regorafenib in colon cancer that we often end up with the wrong dosing schedule. And it may take years to get better, ways to dose and doses. So this looked at the regular dose, which is 6.4 milligrams per kilogram, versus a lower dose, 5.4 milligrams per kilogram. And actually, to steal the thunder a little bit, that dose won and led to an expansion cohort, with response rate being the endpoint, though toxicity being very important. And so what you can see here in these results was actually in the initial part, the response rate was 45%. And if you look at the 3+ was even higher, but it seemed to be higher in the lower dose rather than the 6.4. And this led to that being carried on to the, as the winner to the stage 2, a little bit lower response rate. So overall, when you add 5.4 milligrams per kilogram, about a 38% response rate. The other thing is that, not surprisingly, the higher dose had more toxicity, with yet another grade 5 pneumonitis in the higher dose, but not in the lower dose. So what are the takeaways from this? I mean, clearly patients benefit, particularly if you're 3+. 2+ was lower, even if you were ISH positive. Lower dose is as good, if not better, and something that I think we'll be seeing more and more of because of the Project Optimus. And also that there was no fatal pneumonitis in the lower dose. And I do think another thing that has to do with that is that there's better awareness now of pneumonitis and probably earlier treatment and stopping the drug.
I'd be curious, so when do you think TDXD might get approved? Is it in front of the FDA? I kind of have been surprised it hasn't been approved already.
I agree. And in fact, I was looking myself before this talk to see if I could find out any information. So I don't have any information about that. Though being in the guidelines, it should be able to be, gotten. But I am surprised because this amount of data is really not that dissimilar than tucatinib, for example. And the results look very similar. And I think it's good being able to have multiple options. So I can't answer that question. I don't have the answer to that.
Yeah, I wonder if they're going to do a randomized trial. That happens a lot. And one more question, as long as I have you. Could you explain a little bit more about what Project Optimus is?
So, as I sort of briefly said, by the standard drug development, pathway where you go to maximum tolerated dose, and relatively small numbers, like, for example, historically with a 3+3 design or a Bayesian design, but still the number of patients that we use to determine the dose that then goes into phase 2 is relatively small. And so, we end up with doses that may not be right. And so the FDA actually, realizes this, and they really want people to look at different drug levels. And so remember, and you're familiar with this, irinotecan, we started with weekly, remember IFL, and that was probably the worst, most toxic way to give it. And eventually we got to every other week, or regorafenib. We ended up with a dose that was intolerable, and that's why we used the redose strategy. So this is one of the things I think the FDA is doing that's good. Sponsors are aware of it. They're building this in early, that you have to have, different dosing. You can't just get your, maximally tolerated dose, because as I was taught, the dose you end up with in phase 1 is what you're going to be doing in your phase 3. And it's really hard to go back. So they're asking this question early. This is, I think, an improvement in drug development.
Interesting.
Okay.
Please continue.
Oh, sure. So let's talk about BRAF, which is unfortunately more common in colorectal cancer and metastatic disease. About 5 to 10% of patients have this, and it's generally a bad actor. It's more likely to be right-sided. There is a subgroup that has MSI. They're more likely to be MSI high. And they tend to act more like MSI high patients. Almost all of them are part of the CMS1 subtype, and they have a bad outcome. And there are multiple retrospective looks showing that, well, if you think about it, in our first-line trials with metastatic colon cancer, median survival is pushing 3 years. Median survival for BRAF mutant, especially V600E BRAF mutant colorectal cancer, is less than a year. These patients are resistant to anti-EGFR antibodies. There are actually 3 classes of BRAF mutations. Most are V600E, which is class 1, where it's sort of stuck in the on position. There's class 2, which is relatively rare, which is probably pretty similar. And then in addition, there are class 3 mutations, which are interesting. And now, back in the day, which means not that long ago, when we just had small panels, all they were looking for was the V600E. So that's all you would get. But now that we're doing NGS, we are finding class 3 mutations. They're relatively uncommon. Depends, anywhere between 15 to 20% of the BRAF mutations. And there's some interesting small series that have been done because it's a small number. Rona Yeager, who we'll talk about, and later, actually, in a small series from Memorial, showed that they may actually have a higher incidence of, or may have actually very sensitive to anti-EGFR. And these are kinase dead. And another group actually showed a particularly long survival, which is the opposite of what you see with a V600E. So not all mutations are the same. And so you may get these, and if you get one of these class 3, that's not necessarily the same as a V600E mutation. Um, so let's talk about BRAF in colorectal cancer. It is not the same as melanoma. We know that single agent inhibitors, in fact, Scott Kopetz finally published this. I was part of this trial as well. We used an older drug, vemurafenib, and we screened 400 patients to get 20 to get one short-lived response. So not particularly active, different than what you see in melanoma. And one of the reasons that a number of groups have looked at, Roger Lowe and others have shown that normally there's actually a feedback loop that inhibits EGFR. And when you block BRAF, you actually get rid of that feedback loop. So they're signaling downstream through EGFR through other pathways. And so a lot of preclinical and then clinical data showing that when you combine with an anti-EGFR, much more active in colon cancer. And there's a little bit of data also by inhibiting downstream with a MEK inhibitor as well. And that led to study designs we'll talk about. So this led to the Beacon trial, which Scott Kopetz, who I just mentioned a minute ago, initially presented, and I'll talk about some updated data. Beacon looked at actually encorafenib, which is a BRAF inhibitor, which is now approved, binimetinib, which is a MEK inhibitor, together with the anti-EGFR cetuximab. They looked at the triplet of all three drugs together versus the doublet of just the anti-EGFR plus the BRAF inhibitor versus a control arm, which was FOLFIRI plus cetuximab, or as we would often do, we don't use 5-FU so much in the second line, irinotecan, and with response rate being the endpoint, with secondary endpoints including overall survival. This was approved based on the initially presented data. I'm going to talk about the updated data, which was published by Joseph Tabanera from Vall d'Hebron a couple of years ago. And what you can see is that both the doublet and the triplet had high response rates, a little bit higher in the triplet, though overall survival was exactly the same in the doublet and the triplet. While in the control, not surprisingly, these patients did terribly, and with a significantly shorter overall survival and basically virtually no responses. Now, when you add all three drugs together, you do get more diarrhea, particularly grade 3 diarrhea. The doublet only had a 3%, only a 3% grade 3 diarrhea incidence, lower than the control with irinotecan, and led to the adopting the doublet as the standard of care and the approval. So the question is, can we use these earlier? Trying to go to frontline. Eric Van Cutsem recently published the Anchor trial, which was actually the triplet in first line, showing a very high response rate, reasonable, I would say clinically significant PFS of a little bit under 6 months, and the same incidence of diarrhea that had been seen otherwise. And this led to the Breakwater trial. This is from a presentation. This trial is still ongoing. Trials in progress from Scott Kopetz, looking at the, basically there are two parts to this. The phase 3 portion is just the doublet. There is also the doublet plus chemotherapy versus chemotherapy plus bevacizumab. Remember, anti-EGFR, and we've learned that since the last trial, doesn't work particularly well. That's the primary endpoint. Though the chemotherapy is oxaliplatin based, there's a separate cohort looking at irinotecan based, which is kind of sort of bolted on to that as well. And we're still waiting for this. So the question is that there are actually two questions. One, just the doublet, is that where we should be going in front line? And second of all, does the combination with chemotherapy add something? So now let's talk about RAS, which is kind of the, that is the 800-pound gorilla. That's 50% of colorectal cancers. It's downstream from all these receptors that we've been talking about. It's found in actually not just in colorectal cancer, but about a third of all cancers, part of the MAP kinase pathway. And this has been the great white whale, historically considered to be undruggable. But now, things have, at least it's been cited, the whale has been cited, and there are multiple new approaches, and I'll talk about them ranging from upstream, looking at the adapter molecules, to molecules that are really designed to inhibit the GTP binding pocket. And we'll talk about the data that we have so far. The success story so far has been looking at G12C, and G12C is more common in lung cancer, but it is in about 3% of colorectal cancers. Each one of these mutations, the shape of the pocket is a little different. So many of these drugs are really designed for a very specific mutation. There are two drugs, adagrasib and sotorasib, that have been developed. They're both irreversible inhibitors, and so they block that pocket. And once again, that same feedback loop seems to be important. So there's preclinically and early clinical data shows that combinations with anti-EGFR looks better. So first, let's talk about sotorasib, which used to be called AMG 510. The first trial that was published, Marwan Faki, was part of CodeBreak 100. This was a multi-tumor trial, as often these are. This is talking about the colorectal cohort. There was about a 10% response rate as a single agent, and modest but clinically significant progression-free survival, and really sort of crying out for combinations. David Hong is a phase 1 person, recently presented the CodeBreak 101, a little bit different because they combined with chemotherapy together with an anti-EGFR, panitumumab, plus sotorasib, reasonable response rate, 55%, but remember, this is with chemotherapy, very high disease control rate, and not too bad, not that different than what you would see with FOLFIRI plus panitumumab, but maybe a little bit higher grade 3 diarrhea. CodeBreak 300 is the phase 3 trial that's coming up, and that is sotorasib plus panitumumab in the salvage setting versus what would up until recently be considered standard, which would be TAS-102 or trifluridine, tipiracil, or regorafenib. And though, as we know, that the combining bevacizumab with TAS-102 seems to be significantly better, as was published now recently in the Sunlight trial, that may not be available everywhere. And so it'd be interesting to see how that accrues with that as the control arm. So let's talk about adagrasib. Rona Yeager published this earlier this year in the New England Journal. This is from Crystal 1 and the colorectal portion of that. And so to the left, which you can see as single agent with monotherapy, a little bit higher partial response rate. Most patients had some tumor shrinkage. It's hard to compare between trials, but does have a little bit higher. And then when you combine with cetuximab, the waterfall plot looks pretty good with a higher response rate, around 40%. So the other trial that's ongoing is the Crystal 10 trial, and I'm actually on the steering committee for this, and this is a phase 3 trial with adagrasib plus cetuximab in second line patients who've already failed first line therapy versus FOLFIRI since it's a large international trial with an optional VEGF receptor inhibitor. So let's talk a little bit more about where we're going from here in KRAS, because obviously, we spend a lot of time searching for those 3% that is part of the trial. I know how difficult it is to find 3%, but I think that this is sort of, cracked the ceiling to a certain extent. And there's a lot of interest now with other RAS inhibitors. One thing that's particularly interesting is signal transduction inhibitors are, they only last for so long. So how do you get resistance? Well, often you select out other RAS mutations, which you may be able to target in the future, or other ways to basically turn on the MAP kinase pathway. So what about the other 47%? There are a number of drugs that are in development. I only have so much time. There's some that actually hit all RAS mutations or many different types, for example, G12 RAS mutations, but there's some concern that this may cause more toxicity. There are other G12C molecules out there that are in clinical development, in particular ones looking at G12D, Q61H, and G13C that are also found in colorectal cancer. Those trials are open, and I encourage people to refer patients for those studies. There are other trials looking at adapter molecules. particularly upstream SOS1 or SHP2. They basically connect the receptor downstream to the RAS, to RAS. And then RAS is not just used as a target for inhibitors, but there are a number of different vaccines that are out there using that as a target. It's something that's in the tumor that's not in normal cells, and it is these are presented, and so it's a legitimate target for vaccines. And as a legitimate target, there was even a T cell receptor cell therapy paper, not in colon cancer, but with a G12D mutation that was published in the New England Journal based on work from Stephen Rosenberg at the National Cancer Institute. So with that, any questions, Neil?
No, that was really awesome. That's great. I'm looking forward to bringing it up, a number of these things to Kristen when we have the webinar. I just wanted to ask you about one thing additionally that I saw in your write-up. I'm starting to see things about mRNA vaccines with neoantigens.
There are a number of different, ways of kind of looking at that. There was some really interesting data with that in pancreas cancer, though.
Right.
The endpoint, though, this were in patients who were positive by ctDNA. They seem to have more clearance of the ctDNA. There isn't long-term data, and I think that it's really exciting. And so remember, the T cells that we're using to try to get an immune response were never designed for cancer. They were designed to get rid of virally infected cells. And this is sort of the whole point of that. And so everything that we do really, in immunotherapy, other than NK cells, are really T cell therapy, whether it's checkpoint inhibitors to sort of unmask the tumor to those, T cells that were designed for things like viruses, or whether it's vaccines, or whether it's cell therapy. They all kind of rhyme.
So, do you think there's a anti-cancer immune functioning that, in addition to T cells, or just that's it?
No, I think that there are. It's just probably, and once again, I'm a GI oncologist. I'm not an immunologist. There are people who know this better than I do, but I would say that a little bit is sort of like, the old joke about the drunk who lost his keys, and and the street lamp, because this is what we've been doing. The flip side of that is that probably, there's a reason why this is here and why we've been looking, because that's where we get the most robust anti-tumor responses. There clearly are other things people are looking, for example, at off-the-shelf NK cells that I can't really comment on, but I think that still this is going to be by far the most likely avenue. All these are different ways to try to get different shots on goal to get robust long-term anti-cancer responses, which is what we want. We don't want a PFS of 5 months. We want that tail of the curve with like Pembro in MSI high.